I'm Dr. Lajos Pusztai. I'm a medical oncologist at Yale University, and I lead the Cancer Center Genomics, Genetics, and Epigenetics program. The question is how we use ctDNA to identify detectable, actionable molecular abnormalities in the blood of cancer patients, breast cancer patients in particular. There are a number of technology platforms that enable one to take a simple blood draw and look for mutations that could be targeted by drugs. In the breast cancer space, these are PI3 kinase mutations, estrogen receptor mutations, also increasingly germline or tumor BRCA mutations, as well as some rare abnormalities like NTRK fusion genes or HER2 receptor mutations that activate the receptor. So for each of these abnormalities, there are drugs that have been shown in clinical trials to produce responses, and patients could experience clinical benefit from them. So when do you do this testing? I think it's standard of care to perform a molecular tumor profiling or target profiling in all at first or second line therapy for metastatic disease. And why? Because we want to understand ESR mutation. If the person has an ESR mutation, elacestrant is an FDA-approved drug. We also want to understand whether a person has a PI3 kinase mutation, because if she has that mutation, then alpelisib would be an appropriate treatment choice. But also, later on in the course of the disease, it's first looking for germline or tumor BRCA mutations, as well as for all the other mutations that I mentioned at the beginning that have actionable and targetable treatment options. So the question, what is the utility of ctDNA monitoring in early-stage breast cancer? So ctDNA monitoring, which could allow detection of molecular relapse before a clinically apparent relapse, has been explored in many other cancer types, and it's been very successful to avoid a clinically symptomatic recurrence in hematological malignancies. It's increasingly used now in GI cancers as well. In breast cancer, we have established through multiple small studies that the technology has great sensitivity and specificity to pick up a recurrence at the molecular stage before it becomes clinically symptomatic. However, what's missing is really proof for clinical utility, that early intervention would be the sort of a second line adjuvant therapy would avoid a future metastatic recurrence. There are a number of clinical trials that are testing this question, and I think these are really potentially paradigm-shifting, very important studies, and I would encourage my physician colleagues to participate and put patients on these studies.